All right, everyone, welcome. Today we are diving deep into a really fascinating and, let's be honest, often challenging organism, the fastidious gram-negative rod, Leptotrichia buccalis. We're going to take a complete journey here, from the lab bench all the way to the patient's bedside, looking at it through the eyes of a clinical microbiologist.
This microbe has quite a story. It was actually one of the very first bacteria ever seen, scraped from Antony van Leeuwenhoek's own teeth, way back in 1683. Now, you fast forward to today, and we find it as a life-threatening opportunist in our most vulnerable patients. That's a pretty incredible journey, from simple dental plaque to septic shock. Just a quick heads up before we really get into it, all the information in this explainer is built on a comprehensive Gemini deep search. So if you want to geek out and look at the primary literature yourself, you can find the full list of sources in the linked document. So here's our game plan. We'll start with how this organism was basically rediscovered, then we'll move to the lab bench to cover its key characteristics and the huge challenge of just trying to identify it. After that, we'll explore how it goes from being a harmless bystander to a serious pathogen before we finish up with treatment and prevention. Sound good? Let's get started. Okay, first up, its history. To really get a handle on this organism today, you have to look at its taxonomy and how our understanding of it has changed so dramatically over time. This timeline really shows a long, quiet history with a very recent plot twist. So it's first seen in 1683. The genus gets formally established over 100 years later. But for centuries, everyone just thought Leptotrichia buccalis was a single species. And then, 16S RNA sequencing came along and completely blew that idea apart, revealing we were actually looking at a whole family of distinct species. This molecular revolution totally redefined the entire genus. Okay, now for the fun part. Let's head to the lab bench and talk about the core characteristics. This is where it gets really practical for our day-to-day work in the micro lab. So what are you going to see under the microscope? Well, Leptotrichia buccalis is pretty striking. It's a large, non-motile, non-spore-forming rod, and it has this classic fusiform or cigar shape. Its size is a huge giveaway. I mean, up to 15 micrometers long, with some filaments that can literally stretch beyond your field of view. And you'll often notice those characteristic pointed and blunted ends. But here it is. This is the single most critical diagnostic pitfall. Even though it is structurally gram-negative, it frequently holds on to that crystal violet stain, making it look gram-positive or gram-variable. This is a massive trap. It can so easily be mistaken for a diphtheroid or a lactobacillus, and that's why it gets missed or misidentified, which can lead to the wrong therapy. And on the plate, it's just as particular. It's an obligate anaerobe, though it is aerotolerant. You're going to need enriched media like anaerobic blood agar, and don't even think about looking for colonies for at least 48 hours. The colonies themselves are pretty distinctive, convex, dry, kind of grayish-brown, but the real telltale sign, the thing you're looking for, is that convoluted, almost brain-like surface texture. When you see that, Leptotrichia should definitely be on your mind. Biochemically, it's pretty quiet. Catalase negative, indole negative, simple fermentative metabolism. But its resistance profile, that speaks volumes. It's intrinsically resistant to several really key drug classes, including aminoglycosides, macrolides, vancomycin, and fluoroquinolones. This pattern isn't just a challenge for treatment, it's a massive clue for identification. And all of this leads us right into Section 3, the identification conundrum. Let's take a look at why our conventional methods so often fail us with this particular organism. So here's the deal. Your standard tools might just let you down. Conventional biochemical kits like API, they're notoriously unreliable for this. Even MALDI-TOF MS, our go-to workhorse, often only gets you to the genus level. A species-level ID with MALDI really depends on your database version, and frankly, it's often inaccurate. We see it all the time. Other species like Leptotrichia trevisani getting misidentified as Leptotrichia buccalis. Which brings us to the definitive answer. For an accurate, unequivocal species-level ID of Leptotrichia buccalis, 16S rRNA gene sequencing is the absolute gold standard, period. For any clinically significant isolate, especially from a sterile site like a blood culture, sequencing is the only way to be 100% certain what you're dealing with. Okay, so now that we've wrestled it into submission in the lab, let's talk about its impact on the patient. Section 4. From commensal to pathogen, exploring its clinical significance. Leptotrichia buccalis really lives a double life. Most of the time, it's a completely harmless commensal, just a normal resident of our mouth and GI tracts. But when a patient's defenses are down, it can become a really dangerous pathogen, causing systemic infections like bacteremia and septic shock. And these severe cases, they almost exclusively happen in severely immunocompromised patients. This right here is probably the single most important clinical concept to take away from this entire explainer. Leptotrichia buccalis bacteremia is a sentinel pathogen. Its presence in the blood isn't just an infection, it is a direct biological marker that the patient's mucosal barrier has been severely breached, almost always because of chemotherapy-induced mucositis. Finding this organism in a blood culture is a major red flag for the clinical team.
Okay, so we've identified it and we understand its significance. So how do we treat it? Let's move on to Section 5, Treatment and Susceptibility, and the big challenge of navigating therapy when you have no official breakpoints.
This brings us to a really critical question for any lab, right? How do we actually interpret antimicrobial susceptibility for this organism? And the answer from EUCAST is simple and direct. No clinical breakpoints exist. That's it. This means we cannot officially label and isolate as susceptible, intermediate, or resistant. So what are we supposed to do?
Well, EUCAST gives us clear guidance for this exact situation. Step 1, you perform your MIC testing. Step 2, you report only the quantitative MIC value. It is absolutely crucial that you do not provide an S, I, or R interpretation. And finally, you add a comment that says, no EUCAST clinical breakpoints are available. This way you communicate the result accurately without any chance of misinterpretation.
So how is it actually treated in practice? We can look to guidelines for febrile neutropenia, like the Dutch SWAB 2022 guideline. For high-risk neutropenic adults, the first-line agent is piperacillin tazobactam at 4.5 grams IV every 6 hours. For children, it's the same drug, just dosed at 300 milligrams per kilogram per day. A typical duration for a documented bacteremia is around 10 to 14 days. And these broad-spectrum regimens work so well because they provide excellent anaerobic coverage. And finally, let's talk about the best strategy of all, prevention. Section 6, Prevention and Control, which is all about protecting that high-risk host. Because the infection comes from the patient's own oral flora, prevention isn't about isolation. It's all about protecting that mucosal barrier. The cornerstone here is a structured oral care protocol, gentle brushing, frequent saline rinses, and avoiding any harsh alcohol-based mouthwashes. In some cases, oral cryotherapy, just using ice chips, can also really help. The entire goal is just to maintain that barrier. And this brings us to a final thought I want to leave you with. Given all the challenges in identification, the tricky gram stain, the fastidious growth, the unreliable rapid methods, is it possible this sentinel pathogen is being missed in your institution? Something to think about. If you found this explainer helpful, please subscribe for more deep dives into clinical microbiology. We are really curious to know what's happening out there in your labs. Share your institutional protocols for oral care in the comments below. Let's learn from each other. Thanks so much for watching.